Welcome everyone. I'm Dr. Randall Wolf. This is DeBakey CV Live, Tuesday 5 p.m. Central Time, first Tuesday of the month. DeBakey CV Live, Dr. Randall Wolf, and we're discussing atrial fibrillation, one of the heart arrhythmias, the most common heart arrhythmia. We've got a special show for you all today. I want to start out by reminding you that we will take questions and we try to answer everyone's question. Go to pollev if you're on your computer, that's poll.ev.com, enter DeBakey, respond to the activity. If you're on your phone, it's okay too. Go to 37607, text in DeBakey, D-E-B-A-K-E-Y, and text in your message. I'm part of DeBakey Heart and Vascular Center. The CV Live series was set up by my boss, Dr. Alan Lumsden, and we're in the studio here in Houston at Texas Medical Center, DeBakey Methodist Hospital. I made a call a few weeks ago to someone who had a mini-maze procedure 7 years ago, and I asked him a few questions, and I asked him if people still ask him about his decision matrix, which was pretty popular after Ross made it. And he said yes. I thought maybe it was time to revisit that. There are many of you out there that are trying to decide what's the best way to treat your atrial fibrillation. That's probably why you're listening to this show right now. It's part of your homework to decide what's best for you. And it might be helpful for you to listen to someone who went through your same journey and how he made his decisions, and it'll give you some insight. Ross Wroblewski lives in California. I met him about 8 years ago, or 7.5 years ago. He attended the Stop AFib course in Dallas, Texas, which is still an annual course, with several other people at the time. Ultimately, he made his decision of which way to go with his AFib, and I'd like to introduce Ross, let him explain his story, and sometimes you may have seen me show a short video, which I didn't bring my computer over with me, but of him skydiving. If I can bring it up on my phone, I will, but him skydiving after he had the mini-maze procedure. Ross was kind enough to join us. He's not here at the studio, but he's with us by Zoom. Ross, welcome to DeBakey CV Live. Thanks for joining us. And if you would, kind of tell us your story. I guess you should start with the beginning. You're a pilot, you're an avid skydiver, and then I guess you started having arrhythmias.
Yes, I exercise a lot, and just doing chores and different things like that. I started noticing, well, let me back up. Actually, it was at night. I would lay on my left side and I would get palpitations, and that kind of bothered me just a little bit. And eventually, after a few months, it would subside on its own. But after a few months, I'd be out like mowing my lawn and all of a sudden become short of breath. And during my exercise sessions, it would be the same thing. I'd all of a sudden become short of breath, more so than normal. I wasn't exercising to the level where should be, short of breath, and that didn't seem normal. So, but it would stop on its own, and I'd have weeks on end where there was no problem at all. Obviously, we know that is paroxysmal AFib, but I didn't know that at the time. I just thought maybe I was tired or something like that. And later on, though, it became a problem, especially with skydiving, or I think mowing the lawn was kind of one of the biggest factors, where I would just have to sit down. And skydiving would be the same way. I'd get kind of lightheaded while I was packing my parachute. Interestingly enough, while I was skydiving, it wasn't really much of a problem. But once I got down, the packing portion is a little bit more strenuous. And or when I carry my gear back to the car at the end of the day, I would get this long duration of lightheadedness and hard to breathe and stuff like that. And that at that point, then I said, hey, I need to go see a doctor. So I went to see a doctor and started my journey through the medical profession.
You're one of those people who could tell every time you went out of rhythm?
I didn't know I was out of rhythm, and that's an important point. All I knew is that there was something wrong because I couldn't breathe very well, and I would get lightheaded.
Were you still flying at this time?
Well,
Well, you don't have to answer that.
Oh, okay.
But needless to
Well, let me say this. At the time, I had really no idea what it was, and it didn't bother me when I was flying because it happened so infrequently that when you're just sitting there, it doesn't bother you. So I didn't know that it would affect me. Eventually, when I went on to get treatment and started getting in medications, then I backed off with the flying.
And what treatment did you start with? Do you recall?
Yes. As a matter of fact, I did a quick. Let me pull that up real quick, like.
And while you're looking,
I started off with diltiazem, 120 milligrams, and Pradaxa. I was also on Pradaxa for a short period of time, and then Multeg, 400 milligram.
And were you having breakthroughs on the medication? Is that why you were looking for another option?
Well, so this started in 15, probably before that with the palpitations. But I really started noticing it in 15. Running my regular life, what I found is I would document on a calendar that I have, an Excel spreadsheet basically, that when it occurred, what day it occurred, and then the duration. And after a while, I started to see that the interval between the events was starting to occur more often, and that the duration during the day would be longer. Sometimes it'd go 4 hours, sometimes overnight I'd wake up and I'm still, I could tell that my heart was beating really hard and I was kind of lightheaded. So at that point, I could tell it was a heart issue of some sort. I went to a local, just to, like an urgent care sort of thing. They referred me to a cardiologist who set me up with an EP.
And the EP said you were a good candidate for a catheter ablation?
See, I've been to, I think it's 6 stop AFib, or Getting Rhythm, Melanie's Getting Rhythm conferences. And that certainly is the case, isn't it? Your EPs are just going to always come up with that. So my EP was real interesting. Nice guy. He wasn't my regular cardiologist, but I didn't have a cardiologist at the time. But he presented me, and I always like telling a story because it's part of the matrix, actually, because this goes right into the matrix real well. He gave me 3 options. He says you can do nothing. You can get on medications and see if that works. And your third option is to have a catheter ablation. And then that was it. And this was before I went to the conference. So this happened, I think it was in 15. And for the longest time, I kind of fought it, it was in denial sort of thing. But it obviously got a lot worse. And I went from paroxysmal to persistent, and then on to long-term AFib.
We got some questions coming in, Ross. We're going to take those as we talk. Sure. And to remind people again, it's better to get your questions in towards the first part of the hour to make sure we get to your question. The producers will put that up on the screen again. pollev.com, pollev.com. If you're on your computer, enter DeBakey. If you're on your phone, cell phone, go 37607 and then text DeBakey. And you can also ask your question at that point. Here's a question. Can a person participate in swimming and running of 5Ks, 10Ks, etc. with the AtriClip installed? Well, the answer is yes. We have people that are cyclists that have already qualified for the nationals 2 years out from being out of rhythm continuously. We have a lot of pilots like Ross, and also you continue to jump. You're a skydiver. And,
yes, I am.
And that's a pretty good test. But I don't think you had the AtriClip. I think when I did your procedure, it was probably a stapler, but I don't recall.
Yes, so I probably should have. So I get the question all the time, do you still have your left atrial appendage? And I say, yes, I do. and so they say, oh, well, you didn't have it removed or clipped or anything like that? And I say, well, yeah, I still have it. And I pull out my jar and it's, it's the actual appendage. I asked you for it and you gave it to me. So
that's a good one. Yeah, because for many years I used the stapler. And so
yes.
I stapled the base of the appendage, and the stapler automatically removed the appendage. And you got yours to keep, put it on the mantle.
Yes.
Because the clip at that time I didn't think was that great, but the one that we developed now is a little bit easier to use. It's a little bit safer, a little bit faster than the stapler, which was one of the questions here.
May I interrupt for just a second to ask you a question?
Hmm?
May I just interrupt, just ask you a question real quick, like?
Yeah.
During my procedure, you addressed the left atrial appendage at the same time that you did the PVI or the maze. And I understand you don't do that anymore, is that correct?
I still don't do what?
You don't do those two procedures at the same time, it's two separate?
No, it's the same time.
Oh, okay.
Yeah, it's
that's
the same.
Important because that's what's on the matrix.
The mini maze is I call it a partial cardiac denervation. That's getting the nerves on each side, which is the most important. It's an antral isolation, so we're isolating the left atrial antrum. It's closure of the left atrial appendage. It's intraoperative EP testing. We do some electrical testing. The only thing I've added since 2017 is oftentimes I'll make a line around the superior vena cava because there are a few nerves that might travel down along the superior vena cava, the vein that drains blood from your arms and your head into your right heart. So really, and the only thing that's changed since 2017 is that, which takes about 15 seconds to do that, and using the clip primarily instead of the stapler.
Okay.
But still, the key is it's a nerve problem. We've got to get the nerves. The nerves are on the outside of the heart. They're in the fat pads. So I pay particular attention to testing those nerves and isolating those nerves so that the overall input of nerves from your brain, from your spine, the overall mass of input is decreased a little bit. And people still tell me today, after the mini maze, they just seem more calm. Their heart's more calm and they feel more calm. And I think it's because you get this massive amount of input. It used to be your heart would speed up because a tiger was chasing you. That was the goal of this autonomic nervous system. So your heart could increase the output very quickly so you could run right now. Well, we're not chased by tigers and lions anymore, but we have other stimuli that have taken the place of that. Road rage, political events, I don't have to mention that. Scary movies. Why should your heart be beating outside your chest almost watching a scary movie? It's because your brain is telling your heart, there's something bad that's going to happen, you better speed up. But you're sitting in your armchair. So we've substituted all these stimuli that activate our autonomic nervous system and just bombard our heart, telling it to do things when it really doesn't need to do that. So I think overall, the procedure decreases the amount of autonomic nervous input into the heart that we get every second. It doesn't eliminate it, it decreases it, and that's enough to settle your heart down, if that makes sense.
Yes.
Let me see, I want you to get back to your story, but let me check another question here. How do you normally close the pericardium sac after installing the AtriClip, completely or partially? What is the main purpose of the pericardium sac? The reason for these questions is about trying to better understand the possible inflammation some people have after surgery. Well, if you're a mammal, it doesn't matter whether you're a squirrel or a rabbit or a human, you have a sac around your heart. And that sac protects from infection. So if you have an infection in your lung, it's very hard for it to spread to your heart because you have this sac around your heart. It also plays a part in the normal function of the heart, moving around inside the middle of the chest, a little bit to the left of the chest. So the pericardium has a reason to be there. It's a protective sac. So I think it's best to restore it. So after I open it, at the end of the procedure, although it's not on the video, although we're going to have a new video coming out soon, it will be on that one. We don't show closing that sac just because the video is getting long, but I do close the sac to restore the integrity of the pericardium, not tightly, loosely, so if there's any fluid in the pericardium, it can still escape, but enough that the integrity of the pericardium over time will be retained. Let's see. If meds are keeping you AFib free, is your heart still at risk of atrial myopathy or heart remodeling? Do the antiarrhythmic drugs or something, then it stops. If you're AFib free, you should be not at risk for the atrial myopathy. The atrial myopathy has to do with mainly the heart beating quickly, more quickly than it should for a long period of time. In the lab, to create heart failure in an animal model, we used to put a pacer on the heart of the animal and turn it up to 150 beats a minute or 200 beats a minute, and you will put the animal into heart failure. It's temporary, but you can put any animal into heart failure if you pace the heart quickly enough. And that's what happens a lot of times in AFib. The heart rate is high, and that's not good. That can lead to what we call tachycardia-induced cardiomyopathy. Tachycardia meaning fast heart rate, and the myopathy meaning an inflammation and a structural problem with the heart. So yes, it happens. The good news is it's reversible. I've had many patients who've had this congestive heart failure due to the rapid heart rate over time, and it's completely reversible, and you get your ejection fraction back to normal if you can get back in rhythm. So if you're in rhythm on the meds, that should protect you for the most part from the atrial myopathy. Paroxysmal AFib for 11 years. AFib burdens 15%, no ablations. Is recovery after Wolf Mini-Maze easier than someone with other heart issues after Wolf Mini-Maze? I guess that means if they have valve problems, or maybe if they're out of rhythm all the time. Ross, do you know what percent of time you went to the point where you were out of rhythm all the time, right?
That is correct.
How long do you think you were out of rhythm continuously before you came to Houston? A year?
Yes, about a year. If you remember, I was quite defiant. So even on meds, I continued to skydive, and that was the challenge. The medications were actually affecting, I think, my cognitive skills to where maybe it wasn't reacting or responding as quickly as I should. And being a skydiver, that's not a really good thing if you're flying high performance parachutes. And if you remember correctly, in the middle, I think it was around the July timeframe, I came in a little hard and and messed up my back. And so I had not gone to the 2016 Get in Rhythm conference yet, so I didn't know about your procedure. But I was put into a brace, a torso brace basically, and was luckily able to heal enough or get stabilized enough to be able to go to the conference. And when I got to the conference, I was in this brace. But you said obviously we couldn't do anything with the brace because you couldn't access my heart. And I wore that brace until December timeframe, and then it was freed up. And I went ahead and contacted you, and we scheduled the procedure right after Christmas and at the same time of the Super Bowl. So we had to slip it, to March, as we mentioned.
Well, your case was well, I wanted to ask you just for our listeners. Any idea how many skydives you have performed, a ballpark number, and what percent of those have been since your procedure? Or how many since your procedure, something like that?
Yeah, well, I wouldn't have that off the top of my head. I have 3,838 right now, which
2,838.
3,838.
3,000.
Yes. So several hundred. I used to be more active when I ran a parachute center for 18 years. So I was putting out students or going out with students, and so I was jumping a lot more per day. And life goes on. I still skydive. I just don't skydive as much as I used to. So less skydives afterwards, but that doesn't have anything to do with the after the maze procedure. I've been doing real well. So there hasn't been any restriction due to the maze procedure or anything like that. It's just life.
It always seemed to me that skydiving would be a good test for the mini maze. I mean, I'd be scared to death to jump out of a plane. You do it. Well, you say you don't do it, but when's the last time you did a skydive?
A couple weeks ago.
Yeah, so you're still pretty active.
I think I mentioned to you I was I still skydive. Every month, several skydives a month. I'm also an HOA board member, so I end up getting real busy with that, and then I fly and ride motorcycle still, and so I have an active lifestyle, living here on the coast, sunny coast of California. So busy doing a lot of things, and so you fit a little bit of skydiving in when you can. So as a part of that trip to Toronto for the other procedure, which I'd like to bring that up. That's something you and I didn't talk about. So I just had a hernia.
A groin
surgery.
hernia?
Yes, a groin surgery repair, basically at a Shouldice hospital in Toronto. And so I wanted to get there early and make sure that I didn't have a flight problem or something like that would delay me getting to the hospital, because I had to wait about 3 months in order to get this surgery. I used the same process basically to decide on that surgery as I did with the maze procedure, and we can talk about that later on. But getting back to the skydiving portion of it for a moment, I made sure I was there a week early, and I brought my skydiving, just before I left. I saw that the weather was going to be good, so I brought my skydiving equipment with me. And I raced from Toronto over to Michigan to make a skydive, and that was my 33rd state that I had jumped in. And then stayed overnight, drove across a part of Canada there into New York, and made a jump near Niagara Falls for the 34th state. So I'm still trying to get all 50 states if I can. We'll see if that happens.
So I think that answers the question about an active lifestyle after closing the left atrial appendage.
Now let's get back to the hernia for just a second.
Yeah.
So one of the first things they were interested in is my medical history, and as soon as I brought up AFib, they were quite interested in, okay, is his heart okay? So about 3 months ago, I guess, as part of the preparation, they ask that I meet with a cardiologist, that I have sonogram, stress test basically, and EKG, the whole works. And came through that with flying colors and got my signatures and was able to go up. Now, let's go back to the matrix for a moment. One of the things that is impressed upon me when I went to these different seminars, I went to local seminars as well as the Get in Rhythm conference each year for, I think, 6 years. One of the things that caught my attention and I put on the matrix is, as you get older, we're all going to end up facing other medical issues, most likely, unless you have an accident. I think you and I talked about that once before. Accident takes you out, or just dying straight of old age. It's only a few people are lucky to get that. It seems like it's a medical condition, an accident, or something like that. So, one of my concerns about being on medications or not treating this, and my heart getting weaker and weaker, is if I have other medical issues in the future, I did not want to be blocked from being able to get treatment for those, because I now have compounding medical issues. I have AFib, as well as whatever that other thing
blood
may
thinners.
Be. Exactly. Obviously, they address that. Am I on a blood thinner, because they didn't know whether or not I had the left atrial appendage removed. And I told them, that's all been taken care of. I explained that yes, mine had been removed, and I'm not on blood thinners. Matter of fact, I'm not on any medications. That's the honest to goodness truth. So, but that's partially probably for lifestyle and trying to take care of myself, but maybe a different subject. But I thought that the hernia surgery, that was one of the places where I got confronted with, what is this medical history, and is that still a problem? I just didn't want to carry that into older age. And so for your listeners out there, that's one of the things to consider, is you may be able to arrest this temporarily, but if it comes back and then you carry that along with other issues, it can get more and more complex and more difficult to deal with all these medical issues at the same time.
Good point. Good point. I'm going to take a few questions, then we're going to jump into why you came up with this, well, not algorithm, but matrix that you came up with. Do antiarrhythmic drugs or rhythm drugs damage your heart? Flecainide, diltiazem. Well, it's a risk-benefit ratio with every drug. There's no perfect drug. So there's always some risk and there's some benefit. And what you hope is that the benefit of the drug far outweighs the risk. All antiarrhythmics are also pro-arrhythmic. In other words, they can settle your heart down, but they can also cause your heart to be more irritable, particularly the lower chambers, the ventricles. So that can be kind of tricky. They all have side effects. Ticasine has a significant side effect to the point where, even though it's a pill, you have to be in the hospital for 2 or 3 days to make sure that your heart doesn't react in a bad way to the medication. I use amiodarone quite frequently, regularly, and have so for 20 years. We found that if you use low doses, it's well tolerated. If you use high doses, there are significant side effects. So it's all a risk versus benefit. It's not only damage to your heart, it's your whole body. Same with blood thinners. Anticoagulants is a risk benefit. If you're 80 years old, and this is from a lecture from an esteemed hematologist, he said really your risk of taking the blood thinner once you're 80 is higher than having a stroke. Because if you fall down, and after you're 80, the chances of falling down go up and hit your head and have a bleed into your head, that's a major, major complication. So even blood thinners, or if you were going to have your hernia and you were on a blood thinner, they would have said, well, you have to stop your blood thinner, but we'll probably bridge you with a A blood thinner you can inject into your muscle until 12 hours before the procedure. And then we need to start it right back, and the risk of bleeding during the hernia operation is a little bit higher. So it's risk benefit with all of these.
The capillaries were one of the main driving issues. I wanted to get off of blood thinners, and it was the capillaries as you get older getting thin-walled.
Yeah.
I guess you. That was a big concern to me.
Which explains why you see some people, not all, but some people are on blood thinners who are quite elderly, have a lot of bruises on their arms, because all you have to do is touch the edge of a door accidentally, not very vigorously, and you got a big bruise, to your point. So let me take one more question, and I want to get back to and get into the matrix. For long-standing persistent patients, do you do a more extensive or something? No, I don't, because I'm a firm believer that this is a nerve problem, not a muscle problem. So burning more muscle, I don't think adds anything. We do a partial cardiac denervation in long-standing persistent patients the same way we do with paroxysmal patients. There are some little changes. If someone's had multiple ablations and the back wall's already been ablated, then I will usually ablate the back wall from the outside, because usually the ablation is not complete. Other than that, pretty much the same procedure. Now back to one of the reasons why I wanted to talk to you, Ross, is you came up with this decision matrix. And if you would, just take a minute and take our listeners through why you even did it. If you can summarize that for us.
Sure. So as I mentioned earlier, I went to a number of local seminars trying to find solutions. I did pretty much like I imagine a lot of the folks out there. You know, you try to change your lifestyle. You try taking different supplements. Stop your bad habits or whatever. You start trying to do anything you can, and then you start to do research on the internet, go to meetings, medical meetings, anything that has to do with AFib. And eventually I got to, like I said, Melanie True Hills' annual
Stop AFib in Dallas.
Yes. Yeah. Yes. And obviously, there was a lot of doctors there that specialize in this particular, it's a fantastic conference, needless to say, but a lot of doctors presenting a lot of solutions. And so I'm sitting there writing down notes, and for like all the challenges. So they'll deal with medications. They talk about medications, a lot of things that you just brought up, ablation procedures, different types of ablation procedures. But basically, what it boiled down to is 3 days worth of a lot of technical information. So I'm writing words down, and I'm writing statements down. And I get back from the conference, this is in 2016, and I've got all this information plus what I had already previously researched. And it was like, okay, what do I do with all this? And I just found I was more and more confused. So, I need to come up with a solution. I couldn't do nothing. And so I tried to start organizing it. And basically, it was looking at each one of the options, and I may have mentioned my original .ep says, you got 3 options: no medications at all, or just don't do anything at all. So you have no medications, you're not burning your heart or anything like that. But obviously you can't do that. So, but that was an option. So that was a pro. There's no medication, no surgical risk. Ongoing research might come up with some other solution eventually. But then I started looking at all the presenters had presented this information on slides for 3 days, plus all research, and I found all these cons. And so it was like option 1's not very good. What's the next option? Well, it was medications. So if you kind of scroll down the screen there a little bit, I don't know if you can, let's see. Yeah, if you can scroll down a little bit further, option 2, there you go, was cardioversion or medications. And so there were pros to that and there were cons. But if just to keep it general, you can, and I'll be glad to send this out to anybody who wants it. And I think a lot of us, keep in mind that this is what was available to me at the time, but I try to still stay close to the community and the information. So, the presentations and stuff like that. And I think it's pretty current. Some of this is just natural life stuff, Anyway, so again, just generally looking at it, the pros that were presented on the left side were kind of slim, and the cons on the right side, there were a lot of cons to just staying on a medication and trying to fight with cardioversion, whether it be electrical or chemical, for years and years on end. And so that was like, well, that's not an option. That's not an option that I want. And after I went to the conference, of course, then I was presented with a new option that the EP had not talked about. You can scroll down a bit further. And that was the catheter ablation. Now, there were general discussions about catheter ablation. And so that's where most of these notes came from. It wasn't, in some cases, they removed the left atrial appendage, so it's kind of split on the pros side with some information there. So there's a lot more positives about going with catheter ablation, and that's what my doctor had, or my original EP had presented. But again, there were also a lot of cons, and that's where I think your presentation was late in the conference.
Yeah.
And if you go down to option 4, you and I had an opportunity. Luckily, you were letting people meet with you after the conference and chatting with you for a few moments. I asked some specific questions after your presentation. And so these notes were taken from the presentation. And the cons on the right side, as you can see, they got significantly reduced. I just couldn't apply all the other cons to this particular option. And so that's where I ended up making the decision. So I guess my point to folks is this may or may not, serve you, but I do know that, first of all, that your other patients, if they've been dealing with this for a while, they got anxiety. This takes up a lot of their thoughts, on a day-to-day basis, month to month, and it eats at you. It's stressful to consider. Do you do medications? Do you have surgery? You have all this information from different people, and you got to come to a decision. You can't do nothing. If you don't do anything, then you're going to be dealing with harsher and harsher situations as you get older and older, because our bodies, you need a good pumping heart. So like I said, I just started breaking it down into options and then doing a pro and con for each one. And anybody could do that on a Word document or Excel or something like that. And if it's not good for you, sit down with somebody and talk it through.
Mr. Producer, do you have Ross's email? Because he was kind enough to say he would share it if anybody, there it is. Is that still correct, Ross?
That is correct.
So I'll leave that up there for a second. Why I want to take a few questions that are directed towards you from our audience. First one is, so Ross has been AFib free since mini-Mays. Any breakthroughs?
No, not on AFib. Now, you and I discussed last time about flutter, but you are very straight up during the conference, because the question came up about flutter, and said that, and so this might be a good time to talk about that. I did have flutter before I left Houston. I did have a cardioversion. That was the first one. And then I had no problem for about a year. And then in 2018, I started getting hit with flutter. It was the typical right side flutter, of which, of course, doesn't have any, I don't believe, correct me if I'm wrong, but didn't have anything to do with the
No,
your procedure.
you're
That's
correct. The
just
mini maze is only the left atrium. Yeah.
exactly, exactly. And as a matter of fact, I'm not totally sure. I didn't have flutter prior to getting AFib.
Yeah.
Maybe it was dry. I don't know.
Some people have
So
both.
yeah. So anyway, I kind of went into persistent flutter and went back to Houston after chatting with you and had a typical atrial flutter ablation process, and I've never had a problem since then. So now neither flutter nor AFib
All
for
right.
7.5 years.
Another question for Ross. He had the mini maze procedure in early 2016 question mark. It wasn't 2016. It was early 2017, right?
That is correct. 16 is when I started noticing the problem.
The next question for Ross. Did you have problems with the FAA because of your AFib? A little background, for a regular pilot, you have to pass an exam annually. If you have medical problems, sometimes you have to take an exam every 3 months or so, right? There are different levels.
Right. I just put my flying on hold. So
And it depends on, I guess, what license you're going for. But overall, have you had problems with the FAA because of your AFib?
no, I reported on my, keep in mind I had the link in for 3 years. And so that was very helpful in proving that, I had normal sinus rhythm. And they kept checking, my doctor did anytime I had a flight review. I'm just a private pilot. So
Yeah. Another question for Mr. Wroblewski. What was Mr. Wroblewski's recovery time? I was told 68 weeks before returning to work. I own my own business, and that's a long time to be off work.
Well, I was retired at the time, but I would say definitely not that long. I could have gone back to work, I would say 2 to 3 weeks, really. It depends on the type of job you have, of course, but
Yeah.
if you're working a computer or something like that, um, the very next day after I was released from the hospital, my brother and he was interested in buying a sailboat. So he comes to visit me in the motel. It was attached to Herman Memorial where you were doing the procedure at the time. And we hopped in his car along with his wife and ran down to Corpus Christi to look at boats. So, I was kind of back on the road, within a couple of days, actually, just, hurt, and you have to kind of be careful. But
Yeah. Well, you weren't bungee jumping, but you were out getting around.
exactly. I'm sure I could have sat, and I probably did when I got back here, sat at a computer and it was working. Now, if you have to lift things, that's a different issue.
Let's see. Let's see. If you have AFib after Wolf mini maze, does the AFib gets worse over time? Well, most people don't get AFib after the mini maze. If anything, they get flutter, and it can be from the right side, that's what Ross had, or it can be from the left side. The left side is more common if the patient's already had multiple ablations. And it can either get worse or it can go away. Sandy Schremeyer, who's the administrator for the Facebook site, AFib-free Wolf mini maze, she had flutter. She had had 3 previous catheter ablations, and she did have flutter post-op, but it did pretty much burn itself out by about 12 months after the procedure. She did not have a flutter ablation. So, here's another question related to that. If someone develops a flutter after mini maze, how do you determine if it's typical or atypical, or just atrial flutter that will burn itself out? Is this decision made from the link data or another way? Okay, good question. Well, sometimes the only way to tell is when you're in the cath lab and you do the stimulation, but most of the time we know. An atypical AFib was very rare before there were catheter ablations. Catheter ablations have been around for 26 years now, so now there are a lot of people getting catheter ablations, and atypical or left-sided A flutters become pretty common. But otherwise, before that, it was typical. And typical, we call it a sawtooth pattern on the EKG. It looks like this. Instead of a P wave and a QRS, you see this A wave, and it looks like a sawtooth. That's typical flutter. And it's usually a multiple or a division of 300. The atrium's usually going at 300, and the ventricle goes at 150 or 75. Atypical or left atrial flutter usually goes around 120, 123 beats per minute untreated. And the the QRSs are not regular. It's more irregular. So you can't always tell, but someone who looks at a lot of EKGs can look at it and pretty much tell you if it's right or left, and be right probably 90% of the time, but not 100% of the time. I think the COVID vaccines can cause AFib from my experience. Do you know if the flu or pneumonia vaccines have a reputation to cause AFib? The second part, I don't know. The first part, I think you're right. And that's from my experience. We had some patients who were 14 years out, 16 years out, 17 years out from mini-maze, no arrhythmias. And a week after they got COVID or they got the vaccine, they were out of rhythm. Now, fortunately, this can be treated and go on amiodarone and get a cardioversion. But I saw patients who had no other reason to go out of rhythm many, many years after mini-maze, and it was related to the vaccine or the disease itself. And it's been shown that there is inflammation of the heart muscle with the vaccine and with COVID. So I think there's a causal relationship. I really do. I wanted to mention, okay, we can take Ross's, I don't know if we're still on his, probably not on his email. I did want to mention that Ross also had a nerve tumor next to his spine in the chest that we could see clearly. I think had you already had that diagnosis before I saw you?
Yes.
So you knew you had this nerve spine paraspinous tumor. It's from the sympathetic chain. So at the time of the mini-maze, I also removed that. We shelled that out from next to the spine, and as far as I know, you've never had any trouble with it since.
That is correct. I haven't had, scans, I guess, to check it, but you successfully removed it, and I have not had any indications that I have a problem.
And we did it pretty much through the same incisions we always use. So here's a question for you. We got a few more questions to get through, but I did, and if you have a question, try to get it in because we're got about 10 minutes left here. Looking back on it, Ross, you made this. Let's go back to the decision matrix on the screen like you had before, and Miss Producer. What has changed since you, in your opinion, since you made the matrix, if anything?
Boy, I don't believe anything.
I'll give you my opinion. I'll give you my opinion then.
Okay, let's hear that.
One is, I think, although the information you put on the matrix is exactly from the lectures that you listened to, I think the numbers presented for catheter ablation are very optimistic. Here at Methodist, a study was done with people that had persistent AFib. That means they weren't out of rhythm all the time, but they would go out of rhythm for more than 7 days at a time. And after a catheter ablation, the chances of them being in rhythm a year later were 35%, not 70% or 80%. Can we go back and do a double screen and put Ross's decision tree matrix on the screen, producers, so our readers can see that again? The one that's and that's one. Thank you. You got it. Very good. I think those numbers may be a little bit optimistic. So I would say 7 years later, we're not seeing numbers that are that rosy for catheter ablation. And the second thing has been this almost fascination with delivering the energy a different way. It's a way that's been around for 40 years. It's been used by microbiologists for a long time, but it's direct current instead of alternating current. And this is all the rage with the EPs because the catheter ablation can be done more quickly. However, the midterm results so far show that the new way of doing it, called pulse field ablation, PFA, the new way, pulse field ablation for catheter ablation, although it's faster, the midterm results show that it's no better than the old way of doing the ablation. It's no better than cryo, no better than radiofrequency. So it's good that it's faster, but the results aren't any better. And I predicted that because it's nerve sparing. Well, if you're going to make an omelet, you got to break a few eggs, and you got to interrupt a few nerves if you want the nerves to settle down. So I wasn't surprised to hear that. So from my standpoint, what you did 7 years or 8 years ago is still quite relevant, just with those couple little tweaks, which are no big tweaks really.
Yeah, that's obviously, again, I'm not a doctor, so I wrote those numbers down from the presentations of the EP community. And of course, I also have a note in the right side that the success rates vary dependent on medical center, the doctor, case volume, experience, et cetera, like that.
Yep.
So this could very well be somebody who does it, a lot, and then, so I don't know. It's
No,
I can maybe talk offline about adjusting those numbers if that's true.
Oh yeah. No,
and a disclaimer for all the folks that are out there, this is not something that Dr. Wolf and I came up with, to try to make his procedure look good.
No.
This me just trying to be as objective as I possibly could, based on the information that was presented to me, and I'm 7.5 years out and quite pleased. So thank you very much, Dr. Wolf.
Let's put Ross's email up there again. He was kind enough to share that with us, and if you would like more information from Ross, you can shoot him an email, and if he's not jumping out of the sky, he might get back to you. Okay, let's run through a few more here. After the left atrial appendage is removed, what are the percentage still developing a clot? Well, it should be 0 or close to, well, nothing's ever 0 in medicine. It should be close to 0 if the left atrial appendage was either removed or clipped in the proper place. So this is very technician dependent, very technician dependent. The stapler or the clip must be properly placed at the base of the appendage. If that is done, then the chances of a blood clot there are maybe 3%. You've decreased the chances by 97%, and you don't have to take blood thinners anymore. By the way, blood thinners decrease the chance of AFib stroke by 60%. Closing it decreases it by 97%. I'll take the 97%. Let's see.
Could you address the electrical impulses that may be originating in an appendage?
Thank you for reminding me of that. You're absolutely right. And with the other devices, such as the Watchman device, which is put in through the groin, it's a catheter-based procedure, that does not isolate the left atrial appendage, so it still is electrically active with the Watchman device. The appendage is closed, but the appendage is still electrically active, and that's a problem. Do you recommend Wolf Mini Maze for a patient that hasn't had AFib episodes? And then I don't get the rest, so it must be over a period of time. Generally, if you're AFib free and you're off medications and you're only having an episode a year or episode every 6 months, I would probably wait. Probably too early to do anything, and I probably wouldn't take a blood thinner. You put me on 200 milligrams amio preoperatively, really calmed my heart down very noticeably. And this is a very common thing that I hear. I like its effect. after the Wolf mini maze and weaned off the amio, will having the mini maze leave my heart calm down, or does the heart typically have palpitations after the mini maze but not going to AFib? No, it stays calm for the reason that we discussed a little bit earlier, and that is we're decreasing this massive amount of nerve impulses that are going to the left atrium, the right atrium, around the SA node. We're decreasing the ganglionic plexi activation of your heart. Your heart would probably be happy to beat at 60 beats a minute your whole life, but it gets all this impulses, all this information from your brain saying, I'm getting into a traffic jam, speed up my heart right now. I'm watching a scary movie, speed up my heart right now. Well, it calms all that down, and that continues even after amiodarone has stopped. But we found, and Toshi and I, my protege in Tokyo, both found that people say, boy, my heart just has settled down, and it almost changes some of their demeanors. They don't get quite as excited after the mini maze. It just seems to settle everything down. So there's a very complex relationship between your brain and your heart, and it just takes it down a notch. Amiodarone will take it down a notch, but most people don't want to be on amiodarone for 20 years. The mini maze does it in a different way. I understand the AtriClip's a bit faster to install, a bit safer, easier to install. Are there any material advantage of having the left atrial appendage cut as opposed to having the AtriClip? I don't think so. Ross had the stapler procedure, but those are titanium clips. So you get titanium either way. You either get it in the clip form or you get it in the form of kind of a hair clip, but it's the same. Dr. Wolf, for those on the Wolf Mini Maze site, the matrix is in the files. That is true, correct, Ross? It's on the Facebook site.
That I don't know, but if
probably is.
Sandy says it is, then that's good.
Thank you, Dr. Wolf and Ross. My asthma has disappeared after the Wolf Osuka procedure. We'll take credit for that. I think that's related to the autonomic nervous system. What meds are given after the Wolf Mini Maze, Wolf Osuka procedure? Generally, we both use the amiodarone in the perioperative period to settle the heart down. And why don't cardiologists offer this procedure? Many don't know it's available. When presented to them, they don't believe there is any cure for AFib. Very concerning. Ross, in a closing statement, maybe you should answer that question from the patient's viewpoint. Why don't cardiologists offer this procedure? I think I have an answer, but how do you feel about it?
It's not in their better interest.
Well, that's true. If we don't do it, you don't need it, that sort of thing.
Yeah, that's just an area they haven't specialized in, and I know they have to have heard of it. You know, so the looks I get, I guess when I brought that up before my procedure, told my cardiologist that I was considering that, it's kind of like, okay, well, I guess I'm finished here, sort of attitude. So it's I just don't think, it's not in their field, and so I think it would take a pretty special cardiologist to say, well, that, to explain, and then maybe they don't know everything about it or know enough about it to, talk about it.
Yeah, I guess, my standpoint is maybe you don't offer it, but I think you should at least inform your patient of all the options, which is what your matrix does. And it doesn't mean that you're a proponent of it. Maybe you aren't, but at least you offer all the options to the patient. Not offer, but at least explain to them what they are. And if it's something that you don't do, you say, well, you have to go see somebody else if you want this option. But generally, just like in your situation, it just wasn't mentioned. Must have slipped his mind.
Out of those 6 conferences I went to and several seminars in the local California coast area, that seemed to be a very consistent response I got from patients, that my EP, the electrophysiologist, did not mention that.
Yeah.
So it, for whatever reason, I really haven't confronted, a doctor on that, but that's, like I said, a very common response that you get.
Yeah. I want to thank you for taking time out to visit us again. You've been very helpful to many patients. You probably don't realize it, but I think a lot of patients have paid very close attention to the homework that you did, and you were kind enough to put it out there so other people could learn from your experience. Thank you for doing that.
Sure.
I think it's helped people around the world, Ross. The Facebook site goes to people all over the world, so thank you for doing your part.
Well, thank you for your expertise and for giving me a new lease on life. In preparation for this, I had to dig back through some old archive files just to kind of look at, what were some of the medications and stuff. And here's kind of an interesting thing, maybe in closing. I likened it to flying through space. My atrial fibrillation issues that I had were like they were on a planet that are, millions and millions of miles behind me. I just don't ever think about it anymore. My life is back to what it was like, prior to this issue coming up.
That's a fantastic way to put it.
Fantastic. Yeah, it's and which sometimes concerns me because I know there's people out there that have questions, but after you get 7.5 years out and you're I don't know if I'm per se cured, maybe it would return someday, but I've just gone on with my life and I just don't think about it much anymore. I try to help people, but there's it's just one of those things now. I'm so far from it that it's refreshing and it's great to not have to deal with it anymore. But I also want to be able to help people that are going through the same thing.
It gives you more time to think about more important things.
Yes, sir. It certainly does.
Thanks again for joining us. I think, Mr. Producers, we'll be back in a month, first Tuesday of the next month, with another episode. Until then, stay safe. Hope you voted. And that's one thing that may put you back in AFib if we find out what the results are, depending on which side of the aisle you're on.
Yeah.
Thanks a lot, everybody. Take care. Thanks, Ross. Bye-bye.
Yeah. Bye.